I'm going to go in order of what I see on my screen. And on my screen, Joelle is the first hand that was raised. Joelle, please unmute and ask your question.
Hi, thanks everybody. So I have a question about orthodontia. My son has already started. It's been like a couple of months. So if I choose the high dental plan, is continuing coverage like the rest of his coverage? Can I submit for benefits for that? Or is it only
So
for new?
the expert on that particular piece is not here right now, but someone did ask that yesterday. I'm waiting on confirmation. I promise you that Katina or Olga will get that information out to you. If not today, then by Monday to confirm.
I can
Okay.
actually answer that just based on
Oh.
personal experience. So if you have a new vendor with new insurance, your provider can submit a claim, but it's not guaranteed that it'll be paid, because typically what happens is with orthodontia, it is based on a lifetime maximum. So if your previous insurance has already paid the lifetime maximum, then the new insurance is not going to pay anything additional.
Well, the good news is nobody's paid for any of it but me.
Oh, well,
So
then the new coverage would pay. The new coverage would pay. Yes, ma'am.
okay, and this, I'm sure other people have this question. Once you've met your out-of-pocket maximum for your family, do you still have to pay copays, or is that considered part of your out-of-pocket maximum?
The Affordable Care Act made that so that it is part of your out-of-pocket maximum. It used to not be traditionally, but I do just want to say one thing in that vein. Remember that even when your plan covers 100%, we still want to ask you to still be conscious and good stewards of the money that the plan is paying, because that's what drives the cost for all the coworkers the following year. So even when you're covered at 100% because you reach your out-of-pocket max, we will help you if you allow us, and we hope you will, to navigate through the system to get whatever it is you need at the highest quality, lowest cost. And you, again, I want to remind everyone, you don't have to change providers. You might be encouraged to or incentivized to, but you'll never be required to.
Okay, thank you.
Thank you, Joelle. Next up is Corey.
Yes, thank you. With the realization that the only real option is to pick one of these plans, I have two questions like Joelle. First, how do referrals work? Does my DPC provide me with a list of specialists I'm allowed to see? If they don't give me a list, do I have input in picking the specialist I need to see because I have a history with them? If there is a list provided, based on the fact there are only 4 DPCs in the entire city of Dallas within an hour of my house, I assume I'm going to wind up having to drive quite a ways to see that specialist. How does those referrals work?
Well, a couple of things. First off, if you shoot an email over to Olga or Katina, and they'll forward it to me, and if I can find you a closer DPC, I'm happy to do that. We tried to kind of pick hot spots where employees were located. So that's number one. Number two, you don't have to pick the plan that is the DPC plan. You can pick the other plan where you don't need that referral. But as far as your specific question in that referral, it's largely up to the DPC. The way it works with most doctors is that they're going to first identify that clinically you need a specialist. If you already have a relationship with a specialist, they're going to try and honor that. And then unless there's some extreme circumstance, then that's the one they're going to refer you to. As far as there being a list, the list is the phone book. They can refer you to any specialist in anywhere in the country that you and they feel are best. But I can tell you absolutely you will have input into that. The only time I've ever known a doctor to not to say no to a specific doctor is when that doctor knows from being a doctor that that's the doctor that no one else would send to, especially the doctor's own family. So again, very extreme and rare that would happen. But the point of DPC is that you develop a better relationship and have more time to discuss your concerns. And your DPC's primary goal is to address your concerns. So I'm quite confident the way it would go is that you would talk with them and you both come collectively to who that right specialist is, and the referral would go in at that point.
Okay, so that kind of leads into my second question. Doing some research on this type of care, the concierge style DPC care, I've encountered some concerning stories. What happens if my DPC and I disagree on care? For example, I have a bad back, my son plays hockey, and we routinely see a chiropractor. If the DPC tells me I don't need a chiropractor, my son doesn't need the chiropractor, what's the next steps?
Well, again, I would first encourage you to have a detailed conversation as to why they feel that way. But secondly, you can switch DPCs anytime you want. So if there's a DPC that doesn't align with your values and your what's important to you and your family, then we'll switch you. The switch can be done anytime, and it becomes effective the first of the following month. Also, please note that not only can we add in DPCs that exist today if they're not on the list today, we're going to be adding DPCs to the list regularly. And more importantly, because it's such a better life for the doctor and patient, more and more doctors are flipping from the traditional care to DPC care. So it's only going to become more and more easy to access doctors like that.
Corey, was that your last question?
Yeah, thank you.
Okay. Okay, thanks, Corey. Next up is Kristen Evanishin.
Good morning. So the first question I have is under the DCP plan, what is the difference between the DPC and guided provider versus the any provider? So I'm assuming, and I'm not going to make any assumptions. Can you explain the difference between, and I think it's more about the guided provider. I know what a DPC is, but the guided provider.
So let me just, I'm going to reiterate the DPC, even though you said you know it, and I'm sure you do, but with the DPC, you never have a deductible, you never have a copay, you never have coinsurance. When that DPC refers you to a specialist, you're going to have a $50 copay at that specialist. Depending on what that specialist wants to do, they may be one of the tier 1 providers in which your deductible is waived for things like MRIs and surgeries, or they may not be one of the tier 1 providers, and you may switch if we offer that to you, or you may not. But if you're not with one of the providers that the plan has identified as being high quality and fairly priced, then you're going to have that $500 deductible. As an FYI, we are training the DPCs to recommend you go to doctors that are tier 1 from the very get-go, so that first encounter with them, if anything comes of it down the road, you're already with a tier 1 or guided provider.
Okay, so that means, for instance, a cardiologist could be on a list as a guided provider, but like one that my DPC recognizes as being on the list. And so then it's the zero copay, even though they're a specialist.
It's always going to be a $50 copay for the office visit and the consultation. What's waived is the more major things that doctor may do, like MRIs and surgeries. So you'll pay a $50 copay to the specialist under all circumstances. The question is, when that doctor does more care, is it going to be a deductible and coinsurance, which, by the way, as you can see, is the lowest deductible and coinsurance you probably ever have had, or is it going to be no deductible and no coinsurance?
So then on page 1 of the document, it has specialist office visit under DPC and guided providers as 0. But then it has a $50 under any provider. So are you saying that there is no specialist under DPC and guided provider, that should actually say NA and not 0?
Well, it's meant to apply to the DPC only. It's only the DPC in which you never have a copay.
That I would recommend changing that. That's a little misleading.
Okay.
Then my next question is, under the DPC plan and the any provider specialist, the out-of-pocket for the maximum out-of-pocket, is that a separate out-of-pocket deductible from what is listed under the DPC and providers? So for instance, no. So what I'm seeing on the sheet, you're saying $500, but I see $1,000 here. So I'm just trying to. Those are not separate deductibles. Those are the same deductible.
Well, you're confusing deductible and out-of-pocket. The deductible is $500 per person. The out-of-pocket is $1,000 per person.
I see. Okay, so it's a total of $1,500. Total.
No, it's a total of $1,000.
Okay. So if I'm seeing a specialist, it is still my out-of-pocket maximum is for my family $2,000.
It's $1,000 per person. It's one.
Right. It says
as long as you have a referral, it's not covered at all without a referral. But with a referral,
Understood.
Your worst case scenario in a year for all copays, all deductibles, all coinsurance, all medications is $1,000 per person. Even if you're in as a family, it's still $1,000 per person. If a second person meets the $1,000, that's their out of pocket. And if a third person has any out of pocket, they'd have 0 out of pocket from the get-go.
Okay, so I am confused now because, so if I have 3 people on my plan.
Kristen, let me back up. I'm sorry. I'm just going to try to explain it a different way because I think that I want to make sure that it's clear. So what happens is when you have a family out-of-pocket maximum, if you have 5 people on your plan, right? That family out-of-pocket maximum is $2,000 total for the family. So if you have 2 people on your plan, like say me, my daughter, right? But we also have my husband. If I meet my out-of-pocket maximum and my daughter meets her out-of-pocket maximum, we both met $1,000 out-of-pocket maximum. At that point, the family out-of-pocket maximum is paid, and the plan pays at 100% after that for everyone on the plan. So if my daughter and I meet the family out-of-pocket maximum and then my husband has to have something crazy done, it's paid at 100% because we've met that family out-of-pocket maximum of $2,000.
Okay, that is my understanding. It just sounded different.
I
So,
understand.
okay, that is my, then
And I
that
just-
was my understanding, so that's clear. I just, the main thing I wanted to make sure of is that any provider referrals are not a separate deductible, which you're telling me, no, they are not a separate deductible. It is still only one deductible, so that's good.
That's
And
correct.
then, so my next question is about the RX drug list. So I went on to the website and I downloaded their drug list, but, how do I know what tier my current medications, my children's current medications fall under on that list? It wasn't really clear, and I don't know if we have to actually sign up and have a number in order to really see where our medications fall. In order,
Where did you pull the list from? Where did you get it from? Just so I can look at the
I
same
went
list.
to the True RX site. And they have a link that says formulation something, and it's the RX Sense Performance document.
Yeah, I don't know if that's the right formulary. What I'll do is I will get you the proper formulary and I will post it up in Employee Navigator by the end of the day.
Okay, I think that'll really help everyone. And
Absolutely. Now
then,
remember, guys, I want to remind you of something. With the higher copay ones, the brand name and the non-preferred and the specialty meds, it is very likely that we can get that to you for free. So please reach out to your concierge before being upset at the higher co-insurance or before even picking it up. If we can get it to you ahead of the time, so you only have to get one fill under it, we want to get that to you for free as best we can.
okay, thank you. And then my last question is for the FSA plan. I assume we're getting a new card. I did read that we'll have a card. Are we required to submit receipts for every purchase or only purchases that we make out of pocket and that we seek reimbursement for?
So you're not getting a new card for the FSA now. If you're on the FSA, nothing is changing about the FSA until January 1st.
Okay.
As far as submitting receipts, about 7, 8, 9 years ago, the IRS really cracked down on the administrators of FSAs, which in your case is Health Equity, to ensure that the expenses they're putting on their debit cards are tax deductible, allowable expenses under the FSA. So they oftentimes, even if you put it on your debit card, and especially if it's at like a supermarket or a CVS where there are things that could be eligible and could not be eligible, they will sometimes ask for a receipt. And if you don't send that in, they will usually freeze your account until you do. So it's not consistent, but if they ask for it, I would send it in. So basically, you're going to have to send it in if you do it manually, and you might sometimes be requested for it if you put it on your debit card.
Okay, and currently we receive an email saying we need you to go ahead and submit a receipt for this purchase. Is it going to work similarly to that? We'll receive some kind of a notification that we need to provide documentation for a purchase.
Okay, again, nothing is changing on the FSA. The administrator's
I understand.
not changing.
After January 1st, 2025.
Well, we're still working that out. We'll confirm that and we'll get all that education out to you in November or so.
Okay. All right. Thank you.
Okay, thanks,
Sure.
Kristen. Okay, guys, I have 11 more folks on the list, so let's go through these. It's 11:24. Steve Kidder, you're up next.
Mine should be pretty quick. My question is about the co-insurance. On the FAQs that just came out this morning, and I believe the slide came from your presentation, it shows the co-insurance as being 20%, but in the benefit guide, it shows the co-insurance as being 80%. So
let me clarify.
are they the same? You're just using
different perspectives. The plan is going to pay the 80% and you're going to pay the 20%. And what you're pointing out already came up today. We're going to make it a little more consistent where we can, but even within the industry, it's not consistent. It's they sometimes it's your share, sometimes it's the plan share, but the plan share is 80%, your share is 20%.
Got it. Perfect. Thank you.
Thanks, Steve. Brittany, Matt.
Hey, I'm not sure if this has already been answered or not. I think so. The copay comparison document was great, fantastic, thank you. But I know right now, currently through BCBS, we get a huge booklet about the things that are covered and not covered. Like, for example, like infertility treatments. BCBS will cover up to 3 IUIs and about 60% of those medications that go with it. But here, is it just a general copay? Like, are any of those things covered? Or like, what about hormone therapy? Like, is there a list of our copays for specific things in addition to that? Or is it just a $50 copay across the board? So I think that was 2 questions. Sorry.
Sure. So the $50 copay is typically tied to the office visit and the evaluation and consultation. Anything above that is typically going to either be the deductible and coinsurance or zero if you allow us to guide you through the system. As far as whether or not specific things are covered, what I think you're asking for is something called the SPD, or the Summary Plan Description, which is the very detailed booklet of what's covered, how, when, where, and why, and what's not covered. That booklet is in the process of being created. It's required by law that we get it to you within 60 days after the start of the plan, but it typically takes close to that amount of time just because it is a very detailed booklet. What I can tell you, in the process of you picking the 2 plans, there is not going to be anything that is covered under one plan and not covered under the other. So the coverage will be the same. The out-of-pocket will be a little different, but if it's covered under one, it'll be covered under both. If it's not covered under one, it'll be not covered under both.
Okay. So there's no way that we'll be able to, I mean, thank you guys for extending out the deadline to like April 30th, like if we wanted to make a change, very appreciative of that, but there's no way to know for sure, like what the out-of-pocket will be, or, further on, like that whole big benefits thing until for 60 days.
Well, in terms of what the out-of-pocket will be, I don't know. I couldn't tell you what that would be in advance unless your doctor was going to tell me exactly how much they were going to bill the plan for that charge. And most of the time they don't know that. As far as if you want to know if something specific is covered, I can tell you that if you email Olga or Katina, very importantly, the CPT code. So you'd have to ask the doctor who would provide this to you what the CPT code is, because I can only tell you based on exact thing being done, whether it's covered or not.
Yeah.
But if you can get the CPT code of whatever it is they're looking to do, I can pretty quickly get you an answer as to whether or not it will or will not be covered at all.
Okay, cool. And then just one more time. So what if, for example, like, I'm just going to use Dr. Tanner Moore as an example because his name is just the most prominent in my head, right, from all the presentations. Like, what if he says something and we don't agree? So you said that I could not argue, but like, get a third opinion or get another opinion. Like, that's that process, right?
Dr. Moore, do you want to speak to that directly? Oh, can't hear you.
Dr. Moore, we can't hear you. Still can't hear you, Dr. Moore.
Looks like he's unmuting himself, but it's not working. No.
Okay.
In the
He has to
interim,
change the
I'll
microphone that he's using on this Teams call up under mic. He needs to choose which one he's going to use, which should be
the drop down, the little arrow. Yeah. It's funny. I find more people
on him because he was there in the presentation for the last couple.
Yeah,
days,
no. I just thought it would be good for you to hear from a doctor what their feeling is on that. But
Dr. Moore, can you type the response to that in the chat? And Brittany, did you have another question?
No, that's everything.
Okay, great. Dr. Moore, if
Thank
you would
you.
do that until you work out your audio issues, that would be great. Thank you, Brittany. Angela Walker is next.
Thank you. I was going through the enrollment and I just needed a little additional clarification on the part of the DPC plan where it's the add-on, the tall glass, which I believe is Dr. Moore as well, who's having issues with this, so with his sound. But my question was, how would we know if this is something that we really need to enroll in?
I think the best thing for you to do, honestly, is not enroll in it now unless you absolutely know you want it. There were some people where it was clear that that was going to be the right thing. Just take Dr. Moore by itself for now, and then go and meet with Dr. Moore and talk with him about it. Say what it is you're looking for, and he'll tell you what it is it can provide, and then you can sign up for that later. That is not something that you're locked into if you say yes or no now.
Okay, that was my second question was, is it something we could add on after the fact? Thank you.
It is, yes.
Bye-bye.
Thank you, Angela. Up next is Dan Ruddle.
Thank you, Katina. I have 3 questions. The first one pertains to care.
Dan, we lost your volume, your audio.
They say probably nothing. They draw blood. They find your serum creatinine's 8 times above the normal range. And they take images. You have 4 masses in your abdomen and you have been diagnosed with stage 4 cancer. You're given options of, you can either receive palliative care and eventually hospice, or you can try to extend your life through chemo. What's covered under either of these plans in that scenario, or any other scenario like that with another disease?
I mean, in pretty much every scenario you described, the care would be covered subject to your deductible and coinsurance at the worst, sometimes 0.
Okay. Second question. If we decline coverage, do we also therefore need to do, and go on our spouse's insurance? Do we need to therefore also terminate our FSA because we're now no longer under the company plan?
So in order for you to cancel the FSA, you don't have to cancel the FSA. You don't have to be on the medical plan to use the FSA. If you want to drop the FSA, now is not open enrollment for the FSA. So you would have to have a qualifying life event to do that.
Okay. Then that leads to my next question, is the qualifying life event. I've gotten the letter and I'm trying to work with my wife and her employer on the possibility of adding myself and my daughter to her plan. The question is there a danger that, yes, even though this is a qualifying life event, even though we still have an employer sponsored health plan as an option, we're declining that, and then we won't be able to be added to our spouse's plan? And if that happens, what do we do from there, since we already declined coverage?
We would just allow you to enter the coverage. We would work with you on that.
But what I suggest you find that out before April 30th, because after that date, you need a qualifying life event for May 1st for the medical plan, not the FSA. But to drop or add the medical plan for May 1st, you don't need a qualifying life event. After May 1st, you do. So I would suggest that
can you
you
say
try
that again, please? I'm sorry, I didn't track that. Go ahead.
Sure. May 1st this year is the open enrollment for the medical plan. It is not for the FSA plan. It will be next year for the FSA plan, but it is not this year for the FSA plan. So if you want to come or go on the medical for May 1st, you're free to do so under any circumstance. After May 1st, however, you need a qualifying life event. So my recommendation was that you work with your wife's employer to figure out what's going to happen before that time.
Right. My wife's employer is not currently in open enrollment, and that becomes the question. I know that I can go onto her insurance during open enrollment, but like most employers in America, open enrollment's in the fall. So
right.
The question becomes, if we go ahead.
No, please go ahead. I was going to ask you to clarify. It sounds like
the question becomes, if their benefits coordinator calls us to follow up on the letter and says, hi, we have this request for to change over to our benefits. Do we understand this? The Blue Cross Blue Shield's been terminated. Do you offer an employee sponsored plan? The answer is yes. And then I get denied coverage and my dependents.
I mean,
Dan, if that's the case, you can just reach out to me. Let's table that. Dan, if that's the case, you can reach out to me.
Okay.
Thank you.
Hey, is my audio working now?
It is.
It is, Dr. Moore. Yes. Dan, other
Perfect. Sorry
questions,
about
or was that your last question, Dan?
That was my last one.
Okay, thanks, Dan. Next on the list is Lauren Eggerman.
Hi, good morning. My question was about the hospitalization coverage. It looks like the add-on is kind of like an Aflac thing that you can use to pay your bills. But I didn't really see a lot of details about what is covered hospital-wise if I choose the DPC plan. So I was just hoping for a little bit of some explanation on how that works.
And Lauren, you were referring to the Unum plans, the hospital indemnity plan and the accident plan specifically?
Yeah, I guess I kind of had a two-part question. So in a more articulate way, when I look at the DPC plan explanation, I don't see specifically anything about hospitalization. So I'm wondering what's covered in that regard, because the add-on seems to be like an Aflac type, bill paying kind of hospitalization while you're laid up kind of bonus coverage. So if I don't get that, am I covered in hospitals under the DPC plan?
Absolutely, you are 100%. It's going to cover hospitals very similar to what you're used to, albeit with a much lower out of pocket. That additional hospital indemnity plan is meant to cover, number one, your deductible and coinsurance, help you with that. Number two, depending on the nature of why you're in the hospital, sometimes we have to get things that aren't covered under insurance, like gauze and bandages and Band-Aids. Also, you're often working less often when you're going through those types of things. So that's the point of the hospital indemnity plan. It doesn't affect your coverage at all, and you have full hospitalization coverage under both plan options.
Okay, perfect. Thank you very much. Also, I want to say to David that he did find me a DPC in my area when there were none listed at all. So he was really prompt for that, and I appreciate the help for that. So
Thank you.
Thanks a lot.
Thank you, Lauren. Next up is David Heller. And David, I believe you're in a conference room. So when you start speaking, I'll confirm whether or not we can hear you guys.
Yes, so I am, and I've got a lot of people in here, and they've all got questions. So I don't know how much we're going to be able to get through, but I've asked each table to start with one question, and so I'm going to let them start. Annie, you want to start?
What happens if you choose the Any Doctor plan and your choice of doctor still refuses this insurance?
If you choose the DPC plan, you said, or the Any Provider plan? I'm sorry.
The Any Provider plan.
So I want to stress that happens very infrequently. And what I mean by that is the biggest group of people is going to go to their doctor, show their ID card. Nothing's going to slow you down. Everything's going to go exactly as is. The second smaller group of people are where the doctor's going to push back, but you're going to either ask the doctor to call the provider number on the ID card, or you're going to ask your concierge team to reach out, and then we're going to get them to accept it. That's going to be over 90% of doctors is where you're going to be able to see them. There is going to be a small percentage of doctors that are going to make the decision to not accept your plan, even though there's no reason for them not to do so. They pay the same or sometimes more. They file the claims the same. But there's going to be some that don't, just like there's some doctors that don't take Blue Cross, or if you switch from Blue Cross to Aetna, they took Blue Cross and don't take Aetna. It's going to be very small, but at the end of the day, if your doctor refuses to do it, the only other option that you would have if you insisted on going to see that doctor, and we will absolutely find you an alternative doctor if you want, that's high quality, would be for you to pay up front, which I know is not fun. But the harder part is that you can submit for reimbursement, but you're only going to get back whatever the plan would have paid had the doctor billed insurance, which may or may not be in line with what you paid them cash up front. But let's deal with that when we come to it, because again, we have a lot of ways to compel them to accept the plan, and it's not often that they say a hard no at the end of the day.
Okay, can I just add on to that question just for a second? Since we are this company is largely based in Alamance County, have you checked with doctors in Alamance County for the Any Provider and seen if there are any that will take this insurance?
I didn't need to do that because I can tell you there already are that do take this insurance.
Do you have a list of those?
We're very hesitant to give out a list because the list that we have of doctors that we know take this plan, if your doctor's not on there, it would lead you to believe that your doctor doesn't take the plan, and that is absolutely not the case. It just means that we probably haven't encountered that doctor under a plan like this yet. So if you need a doctor who you know will take the plan, email your concierge or call your concierge and say, hey, I need a cardiologist in Alamance County that I know will take my plan, and they'll give you a bunch of options.
Well, I just will push back real quick before we get to our next question. A list would be valuable so that people could evaluate their personal decisions right now. But I see that you're not going to provide that. Ellen, do you have another question? Okay, go ahead.
The next question is, where do I order insulin pump supplies and Freestyle Libre supplies on the any provider plan?
It's the same as the DPC plan. So for anyone else who might have that question and is considering the DPC, it's the same. We have a vendor called Connect DME, and if anything you order from them will be nothing out of your pocket. It has to be ordered by a physician, but then when the whatever it is you need has to have a script tied to it. But if you call your concierge team, they will connect you with Connect DME, and you can order it with nothing out of your pocket.
Thank you. Our next question.
I have a pacemaker and it's remotely checked quarterly. Is this covered?
If it's if it's medically necessary, absolutely, yeah.
Well, it is. It keeps me alive.
I certainly don't want you to do anything that doesn't keep you alive. But again, as long as it's medically appropriate to be done quarterly, then it will be covered.
Okay. Is this prescription drug plan as good as Medicare?
Way better.
Okay. And
are you asking specifically, can I just clarify, are you asking like, is it in my opinion better, or are you asking, is it considered credible coverage so that if you take Part D later down the road, you don't pay a penalty?
That's exactly what I'm asking.
Okay. It is, in my opinion, much better, and it is also credible, and you will not pay a penalty.
Okay. My coworker and I have tried to figure out the long-term and short-term disability cost. And if we did it correctly, it's pretty high. It's much higher than what I have right now.
So the long-term and short-term disability are done by age bracket. I think it's done in 5-year age brackets. And like 90% of the age brackets are less than Colonial, but I believe there are 1 or 2 that are higher. You may want to consider keeping your Colonial in that case. It's going to affect very, very few people, but we kind of had to make a decision for the majority. But I do recall that a couple of age bands were more expensive under the unit.
Okay. Thank you very much.
Sure.
Okay, so a couple of other questions. If you visit urgent care, do you have to go to certain ones, or can you go to any urgent care?
You can go to any urgent care, but we can also, let you know ones that we already have relationships with, which just make it a little easier. But no, if in urgent and certainly emergent situations, just go anywhere.
And are the benefits the same at all of them? Are they, 80% covered? What's the copay upfront on those?
It's going to be covered at the same in all of them, with one exception. There are some urgent care centers that are also primary care doctors. And I find that sometimes they bill as a primary care doctor. So if they bill as a primary care doctor, you're just going to have a $25 copay. But if they bill as an urgent care center, then it's going to be a little higher. I'm looking that up right now. Just give me 1 second to tell you what that is. Hold on. Yes. It is subject to your deductible and coinsurance, the urgent care. But obviously, because the charge is going to be a heck of a lot less than emergency room, your deductible and coinsurance will be a lot less. Also, if you're on the DPC plan, don't go to urgent care. You should never have a need to go to urgent care. You should call your DPC. Emergency room could be a little different, but urgent care, you should call your DPC.
So are you saying if you're on the DPC program, you don't go to urgent care for any reason?
You do.
So if
I just don't recommend.
If I'm an hour and a half away from your doctor, you want me to drive an hour and a half if I've got an emergent need?
Sir, I didn't say that. I said call your DPC is what I said. Didn't say go there. Call them.
Well, thank you. So I may have missed this, but if you're seeing a specialist like a dermatologist because of family history issues that you've previously had, and you prefer to stay with that specialist, do you have to be referred by a new doctor, or can you continue to go with that specialist if you're on the DPC program?
If you're on the DPC program, you need a referral to go see that specialist.
Okay. I think we may have some more questions later, but that's it right now.
All right, thank you, David. Okay, we have a few more people on
I'm
the
sorry.
list.
One more, Katina.
Okay.
You're on the DPC plan. Does your doctor get all your medical records from the doctors you're seeing now?
Sure do. Absolutely. Yes, ma'am.
Who takes care of that? The patient?
The doctor. No, the DPC doctor. There was a law passed that was part of the Affordable Care Act that requires doctors to share information. And so they're actually able to pull your records from my chart, like if UNC and Duke. They might need a form signed by you for some more independent doctors, but I can tell you that I just did my onboarding with Dr. Moore. I just had to tell him which doctors I've seen in the past and sign a form, and he took care of everything.
Okay, so he has time to review all that and get to know the patient before the patient comes to see him?
Ma'am, that is the entire benefit.
Okay.
What was that, Dr. Moore?
Okay, thank you.
We have so much more time than other doctors do to review that stuff. As a matter of fact, sometimes when I have a question, I can take the time to call the other clinic to make sure that we're understanding right and that they communicated the information right. Sometimes they'll have a diagnosis in your record that they didn't actually diagnose you with. They just were required to put it in to order a medication. So a lot of that stuff needs to be kind of combed through anyway after a few years.
Okay, thanks, Dr. Moore. And thanks, David, and all of you in the room with David. We have 7 more people whose hands are raised. So I'm going to ask you to choose your single most important question to ask. And next up is Michelle Felt.
Hi, thank you. Shoot, I haven't had time to figure out which is my most important, but all right. So this one you touched on, but I just need a little, I don't want to have to choose. Anyway, I need a little clarification. So regarding for the any provider benefits, let's say it's self-directed or concierge directed, let's say I hit the $4,000. So I guess I'm going to stick with tier 1 just for example, but I hit the 4,000 as an individual with my healthcare needs. But what if I have some kind of event that is huge? I wind up in the hospital for extended periods of time and, maybe there's an ambulance taking me there. Maybe I need physical therapy after, whatever. It just gets really huge. Who pays beyond that 4,000?
So I want to be clear that even up to the 4,000, you still had the plan pay for some things. You either had them pay when you paid a copay, they paid everything above it, or once you got past your deductible, the plan was paying 80% and you were paying 20%. So the plan has been paying all along, but it's the plan that continues to pay that. It's your plan that continues to pay that. And you would have zero out of pocket. Once you reach the $4,000 out of pocket, everything that is covered under the plan is covered at 100%.
Okay, thank you. Okay. Okay, thank you. I have more questions, but I'll ask concierge, I guess. Thank you.
Okay, thank you, Michelle. Napoleon?
Yes, mine is really simple. I've been hearing talking about doctors tier 1 and tier 2. What's the difference?
So the tier 1 doctors are ones that we have identified as being in the top 25 percentile for your specific need. So if it's a knee surgery, we look at knee surgeons who work on people who are your age, your ethnicity, your gender, and have the best outcomes. Then we find the one that's willing to accept a reasonable price. And if you go to that one, then you will have no out of pocket.
Okay. Thank you.
Thank you, Napoleon. Michelle Hodge?
Okay, Katina, we're in a conference room with 25 different people. There are a few that have questions.
Okay, can we choose 2 for now, and then you email us the list of the others after this call?
Okay. Okay, I have 7 questions, but I guess I got to choose the most important thing, which is my family. And my husband is sick and had to get an operation this month, and he is covered at his work right now. So we have decided it's not best to put him on this plan right now, but if for some reason he can't go back to work and I need to add him to my insurance, well, I'll be able to do that later on.
Yeah, if he loses his coverage because he's no longer working at his job, that would be a qualifying event, but it has to be timed for when the coverage end at his current job. So as long as you let us know plus or minus a couple of weeks of his employment ending, then he would be able to come onto your plan as of that date.
Can I add on to that right quick? I had to do the DCP plan, because that's what I can afford. Will they be able to take care of him, being that it's a cardiological problem?
Yes, ma'am. I mean, I'm quite sure that they would keep him seeing his current cardiologist if he's in the middle of something. Absolutely.
Okay, Michelle, is there one more question?
Yes. Okay, so I have a question. If you go on Medicare, which I'm getting ready to do, and if I was to take this insurance now, so when I do get Medicare, can I cancel?
So unfortunately, going on Medicare is not a qualifying life event, according to the government. So you would be able to cancel come the next open enrollment, but you wouldn't be able to cancel as of the date that you go on Medicare, unfortunately. I think that's crazy. I think it should be, but not our choice, unfortunately.
Okay, we do have other questions, Katina, but I guess we'll have to send an email.
Yes, that would be appreciated. Thank you, Michelle.
Uh-huh.
Candace Berkeley. Candace, you're up next.
Morning. I had the chance to speak with Dr. Moore this morning about the DPC plan. I just had a quick question about referrals and going to something like an infusion suite if you're getting an infusion every month. So I know does that also have to be qualified under like a guided, like would I have to pay a copay to do something like that?
It looks like Dr. Moore is getting ready to say something. I'd be willing to bet, and he can confirm this or not, that he can do the infusion for you, which means you wouldn't pay anything for the infusion. You just pay for the drug itself, which we can usually get you for free. But Dr. Moore, do you want to speak to that real quick?
We had discussed this morning. Are you still not able to hear me again? Can you hear me?
Yeah, we can hear you.
Yes, we can hear you.
Okay, good. Like, what the heck is happening? So we discussed this morning, and yeah, that is a potentiality. But what I'd recommended that she ask is if there's a benefit plan specific issue with her having that paid for. And I don't think that there is. If she could get a referral to the infusion clinic if she needed it, and with no problem. And it sounds like you need it. So I don't anticipate there being a problem.
Yeah, but I guess what I'm asking is if I get the referral from Dr. Moore, because is that considered a specialist and I would have to pay $50 every month, or?
It's actually considered a facility, which means it would either fall under your deductible and coinsurance, or if we're able to find a tier 1 infusion center for you, then you'd pay nothing. You'd still pay for the drug, but you wouldn't pay for the infusion.
Okay, so as long as it's that tier 1, it would be covered completely if I'm on the DPC plan. Okay, that's what I was wondering. And the coinsurance.
And I just want to clarify.
Okay.
We're not always able to get a tier 1 for everything everywhere. We try our hardest, but it's not always available.
That's understandable. And the coinsurance for the DPC is still 20%?
Yep. And your out-of-pocket maximum's $1,000. And once you reach that $1,000, every doctor's covered in full, your drugs are covered in full, your infusions are covered in full.
Which is a lot different than Blue Cross Blue Shield, that's for sure.
Yes.
Yeah. Okay.
Yes.
Thank you.
Sure.
Thank you, Candace. Hoover.
Okay, this is actually Meredith Curry. We're in a big meeting room, so I'm on Hoover's computer. I had a lot of questions, but to narrow it down to one, with the DPC plan, let's say you need a referral for a surgery or a birth or anything like that, is distant to your location like kept in mind, or is it just you have to go to whoever they refer and they're determining where they can get the best but cheapest care. And if that's 2 hours away, that's 2 hours away.
So you won't ever be forced. Oh, sorry. Go ahead, Dr. Moore.
This is shared decision making. Your DPC, speaking for all of them, not just me, your DPC is really your ally to work for you as the patient that needs what's best for you. So, you get to sit and have this discussion. I would imagine no DPC is just going to pitch a referral off into space and hope that you can figure it out and it's not what's easy for you. I mean, we pretty much are in the business of making the healthcare system easy and accessible for our patients. So now you will be given, you'll be given transparency on the situation. So if we say, hey, there's a doctor 5 minutes away, but half the people that he treats get an infection afterwards. But there's another doctor that's a couple hours away and he doesn't have any infections. You can decide. And that's more of how that would be handled.
Okay. Thank you for that insight.
You're welcome.
All right, thank you. Sarah, I saw your hand earlier. It was lower and now it's back up. So Sarah,
Yeah.
I'm assuming you have a question. Great, thanks.
Yeah, thanks, Katina. This is maybe for the CAS folks in particular. So they're obviously in North Carolina, we have the benefit of having some really terrific healthcare networks here with Duke Health, UNC, et cetera. Is there any advantage to, and I know that there are similar ones in Alamance County as well, so I'm not as familiar because I live in Wake County, but is there any plan for you guys to work with those networks in particular to get coverage so that us as employees and consumers don't have to go call individual physicians to get this done? I'm just wondering if there's any efficiency in having you guys reach out on our behalf for coverage for those that choose to keep our current providers? Or do we have to go like individual by individual and physician by physician to go through the process of getting this recognized as adequate coverage?
So I'll speak to that if Kasha or Melissa or Colin, you want to weigh in, but unfortunately, Duke or UNC doesn't find Carolina Biological important enough for them to be willing to do that. We've tried. If you guys had 5,000 people, then they might listen to us. But with just 300 employees, they're unfortunately not interested in working directly with you. However, that doesn't mean that you need to call each and every provider. Again, the huge majority of times when you go see a doctor, you're going to make your appointment, you're going to show up, you're going to give your ID card, you're going to pay your copay, and you're going to walk out. That's the huge majority. But if you do encounter any resistance, then either ask them to call the provider number or let the concierge know.
Yep. Okay, perfect. Thank you.
Sure.